Hello, everyone, and welcome to the next edition of the Academy by Acclivity Health Solutions. Continuing on the theme of readiness, this concept considers for the few minutes we'll spend together, value-based care data. So what kind of data is available? How do you make use of it? What should you be focused on? Those will be the concepts we cover in this particular academy. And I want to sort of start with the history of data itself in healthcare. If we go back a few decades now and think about what kinds of data have been created, consumed, and passed along the ecosystem throughout the ecosystem of healthcare, it really starts earliest with how we pay for things. So all of the revenue cycle side, anything that has to do with claims and benefits, everything having to do with episodic or longitudinal care as it's paid for in the United States fits into what we call the first platform. Shortly after that was created, most of that still is kind of mainframe based, very much a legacy fabric and from a technology perspective, creating, very specific kinds of transactional data sets around payments. So it's called X12 or HIPAA transactions. So that's the 1970s in the sort of first platform. Around the same time, or just a little bit later, would have been the electronic health record. These typically form the basis for an encounter. They include SOAP notes, so subjective, objective assessment and plan. Think of a primary care encounter you've had as a patient. You'll get picked up from the waiting area. They'll take your height, weight, blood pressure, temperature. They'll ask you subjectively, what's going on today? Why are you here to see us? You could describe a sore throat or fever. They'll do some other objective measures. They may look in your ears, your eyes, your nose, etc. And then they'll make an assessment and often write a plan, which is a prescription or a referral in most cases in that example. So that's the second platform. The third platform is pretty much everything else, right? It's all the population health tools. It's all the disease registry. It's all the information captured from devices that might be attached to a person or a location of care. Really, those things surface in the third platform, this bigger, mostly current state build. And those get surfaced back inside of the utilization review and management teams inside the first platform or inside the electronic health record for persons that might be doing point of care or centralized care for patients that are often at risk. So that's sort of the way we think of legacy capabilities. And then if you take an organization like Acclivity, who has its own tech stack, we think of us playing a role that sort of marries these two things together. Remember, X12 transactions, very much administrative data. Clinical data lives here, and HL7 transactions. So they don't talk to each other, often say, this is like airports, this is like rail cars and trains. Like they can be, near each other, but you don't fly trains and you don't put planes on rail tracks. So often that has to get done outside of the platforms and then commingled back inside of the individual's specific stated platform. So that's one bit of history. When you think about what a third platform might need to work with, it isn't just claims and benefits and electronic health record data, which we talked about as the legacy platform. So again, 1970s, 1980s, when they first started being built and scaled in the United States. You also had the invention of the Health Information Exchange. Often state or region-based organizations would stand those up. They could do some of the exchange of data between these platforms. They often might do event notifications. So think admission, discharge, transfer notices. You also have all of the medications that are ordered and filled under pharmacy benefit management. There are third parties that get delegated for parts of the risk. Think of managed care organizations or managed services organizations. They all have their own data. So these are examples of the kinds of data that come into a platform. Once the data is captured here, it actually has to be massaged and transformed into unified records. So if I'm Jeremy, the patient, my claims are going to live in its own system. My electronic health records are going to live in a number of different charts across different vendors' capabilities. I live in the state of Florida, so Audacious Inquiry, now Point Click Care, is behind the scenes in the state of Florida. Pharmacy benefit management systems include 5 or so really big national scaled organizations. You can tap into SureScript, CVS, et cetera. Managed care organizations, I can throw a rock in South Florida and hit 15 of them out my window. So it's a lot to capture, and you've got to turn that into Jeremy's record. So where is Jeremy known across these different components? And then for a real third platform, it's got to serve point of care clinicians with clinical decision support. It has to support centralized navigator case managers in both the health plan side, the quasi health plan side, think ACO or risk bearing entity that's delegated, and the point of care clinician who's using a quality team or utilization team to improve his revenue. You also need to support third-party software. So think of this as really, I need to plug into an EHR. I need to plug into a utilization review and navigation management, case management system. And then over here, if you're really doing a good third platform, you got to engage the patient and the family as users that are often proxies for the patients that might be their children, or if they're aged adults taking care of their spouse, or maybe younger persons taking care of parents that are aging into dementia or other issues where they may need clinical proxies. Again, you've got to support them. And then obviously the third platform, just like the first and second platforms, are going to have roadmaps where they continue to bring value to the market. So these are the kind of things you'd expect to see in a roadmap. So these are the kind of data items you'd expect. These are the kinds of components that make up what really works inside of value-based care and these connections that need to get created. And this is an example of what you might expect to build around your approach to value-based care related to data. Thanks for your time today. Again, info@acclivityhealth.com if you want to suggest more content or to discuss maybe what we might bring to the podcast. Talk to you soon. Have a great day.